Hey, everybody. Welcome back to Palm Peeps. Thanks for tuning in. This is actually going to be the last episode in our summer series, our summer rapid fire journal club series, reviewing landmark literature in ARDS. We certainly are not done with all of the papers about ARDS. There's always more to read, but this is going to be the last episode where we review a paper in detail. As always, for this series, and joining me is our associate editor who's in charge of rapid fire journal clubs, Luke Hedrick. Hey, Luke.
Hey, Dave. Happy to be back.
Yeah, absolutely. Always happy to have you. I think one thing we've talked about extending beyond this was discussing some of the ECMO literature around ARDS, but we've actually already done on Pulm Peeps an episode on VV ECMO for respiratory failure. And so if you're interested in that, we discuss a lot of the literature in that episode, and I encourage you all to go take a listen. So, Luke, what are we going to talk about to take us out at the end of this series?
Yeah, so today we're going to be talking about driving pressure, and in particular, the paper from Amato et al. That was published in the New England Journal back in 2015 that kind of kicked off the idea of driving pressure as a metric to look at.
Absolutely. And I think what differentiates this paper from some of the other ones we've studied is that this is not a randomized control trial. This is a retrospective look at a large amount of data. I would say it's one of the most influential retrospective papers in terms of shaping our practice, just because the findings are so interesting and pretty much convincing. But before we get too ahead of ourselves, why don't you tell us some of the background leading up to this paper?
Yeah, so like we've covered over the course of the summer, lung protective ventilation, and which by that we mean a collection of ventilation strategies using low tidal volumes, lower plateau pressures, and higher PEEP has been associated with mortality benefits in people with ARDS, presumably by reducing the mechanical stress on the lung. But trials that have manipulated individual components of that package have shown some conflicting results. And I'm sure we can all imagine a time where optimizing one component has led to worsening of another component. Most trials in this space try to reduce this vent induced lung injury by scaling the tidal volume to someone's predicted or ideal body weight, where what we're essentially trying to do is normalize tidal volume to lung size. But we also know that ARDS can dramatically reduce the proportion of lung that's available for ventilation, which at the bedside is a lower compliance. And so delivering that same tidal volume to two lungs that are physically the same size but have different compliances causes more mechanical stress in that less compliant lung. And so here, the authors proposed that normalizing the tidal volume to compliance instead and using that ratio as an index to indicate the quote unquote functional size of the lung would better predict outcomes in ARDS than tidal volume alone. And then they named that ratio, the tidal volume to compliance, the driving pressure. The nice thing about that is that you can calculate this pretty easily at the bedside in patients who are not making inspiratory efforts as your plateau pressure minus your PEEP.
Very well said, very succinctly described. And I think this has been a major problem in ARDS. Two problems that you comprise there. The first is that we know ARDS by definition, because it's a syndrome, is extremely heterogeneous. So this is a clinical syndrome just based on the presence of respiratory failure occurring in an acute setting after an insult and with certain hypoxemia requirements while getting a level of PEEP. That's not all just from heart failure. And because that's a pretty broad definition, patients can have all sorts of different respiratory mechanics within that same acute hypoxemic respiratory failure. And so we sometimes see conflicting results in different patients if we use the same strategy. And then the second thing that you pointed out that I think is really important is that we're titrating multiple variables at once on the ventilator and they influence each other. And so it's not always apparently obvious what your next move should be if you're trying to optimize somebody's lung function. And as you said, I love this. It's a very easily measurable metric. And just to go out through the math a little bit, we're talking about tidal volume over compliance. And because compliance is a change in volume over change in pressure, if you rearrange that equation, you end up with a pressure. And we're going to deem that driving pressure and use it, or they deemed it driving pressure. And we're going to reference that for the rest of this discussion. As I alluded to, this is not a randomized trial. This is looking back at some other trials. So a little different than what we've talked about. So can you tell us about the study design and who we're taking a look at?
Yeah, so this, like you mentioned, is a little bit different. This was a retrospective, individual patient level analysis of 9 major prospectively collected ARDS trials. And the total number of included patients when they pulled all these together was a little over 3,500. When they pulled all this data together, they had to create a survival prediction model kind of to based on the illness of the patients that were in these different studies. They derived that prediction model from the 4 early RCTs of various approaches to low tidal volume ventilation that had about 330 patients there. And then they tested, refined, and validated it with the ARMA trial, which is that landmark low tidal volume ventilation paper that we've covered before. That was about 860 patients or so. They then retested it with a more recent validation cohort of 4 RCTs of high and low PEEP strategies. And that's where kind of the bulk of the patients were that they looked at. There were like 2,300 patients in that. And so, saying that again, they developed a prediction model for survival from 4 early RCTs. They then refined it and validated it with ARMA and then retested and revalidated it with the high and low PEEP trials that are a little more recent.
Thanks for going through that. Yeah, I think one of the advantages of having this network of trials is that we know these are a bit of a controlled setting. These are all occurring as randomized trials with some different inclusion exclusion criteria and a little bit of different approach that was studied. But we have this large collection of patients, all of whom had ARDS. And so hopefully we can use that information. And this same cohort of patients has been used in multiple retrospective studies now to try to garner a little bit more physiologic or biologic information. And anytime you're reading a paper that is retrospective like this, that is using a model that was generated on part of the data set, then the key you want to see is that they have validated and maybe even revalidated, like you said, that they did in this study. That lends a lot of credence and makes us feel comfortable that the prediction model we're going to use is appropriate for the patients that we're studying. So with that setup, we now have a large number of patients that we can use to analyze some of these variables. What outcomes and variables are they interested in looking at?
Yeah, so the major outcome they looked at here was 60-day mortality. And then there were a handful of independent variables that they tested as predictors, essentially, of that primary outcome of 60-day mortality. So they looked at whether someone was assigned to the treatment or the control group. They looked at baseline severity of illness, which they used a handful of different calculations to get at that: Apache scores, the P to F ratios, et cetera. There was a bucket called characteristics of patients that is not quite as well defined, but is getting at some of that baseline demographic information. Then their initial ventilation variables. So, what was the tidal volume and plateau pressure over the first kind of 24 hours from inclusion? Separately, they also looked to see it at averaging those over 3 days, and that wasn't any more predictive. And so they just, for the sake of simplicity, stuck to the first 24 hours. And then they excluded folks who were on pressure support or who had a respiratory rate that was higher than their vent settings, which would imply respiratory effort. Because if what they're looking at is this plateau pressure, which is only valid if someone's not making respiratory effort, having a patient who's doing that is not necessarily going to be um, meaningful data. It's not really applicable in that setting.
Yeah, absolutely. As you're indicating, driving pressure is really for these patients who are in moderate to severe ARDS in the early stages of their treatment, where we're really taking control of the ventilator to try to reduce ventilator induced lung injury. And by definition, for these trials, that means that they shouldn't be having respiratory efforts of their own, changing their transpulmonary pressure on their own. Everything that happens in their respiratory system should reflect something that we're setting on the ventilator. And you went through a bunch of the variables that we're looking at. I think these all make sense. These are the things we think about when we're trying to differentiate these patients. Severity of illness, and they use these broad scores, and then P to F, which is the most validated phenotyping system that we use in ARDS to think about severity of illness. Characteristics, we certainly want to know how old these patients are and who they were before they had ARDS, because that will influence mortality. And then we want to know what their baseline vent settings were and a variety of different factors around that. So we have this good setup of patients and variables that we want to take a look at. How they're then going to go and try to have a prediction score that is going to help them assess which event setting variables are the ones that are most important. So, how do they go about deciding which of these variables to include?
Yeah, so essentially, if a variable had a simple association with survival, then they added it to a multivariate analysis. And if after doing that, it was still associated with survival in both, then they included it in the final model. And so they basically looked at each of those and says, does in and of itself, is this associated with mortality? If so, let's throw it in the pot. Is it still associated with mortality? Yes, great. Then we'll include it in the final model.
That's
And
great. And this is one of the ways that we go about identifying variables in any retrospective look, right? We want to see a univariate association, but then we want to control for a bunch of other variables and make sure that a parameter still comes out in the wash as being important, because there are certainly some that will be collinear with other variables and that they become not important anymore as long as you're controlling for something else, and some that become less meaningful once we're looking at the global picture.
Yeah, and so after doing all that work, what they ended up finding was that age, someone's baseline risk, or like their Apache score essentially, their pH, FiO2, and their driving pressure was what was associated with survival. And then they were able to replace FiO2 with their P to F ratio through some math, essentially, which is nice because P to F is externally validated. And so it's nice to see that reflected here as well. And once they had done all that, what was interesting is that driving pressure predicted survival as well as someone's baseline risk did, their Apache score did. And so, interestingly, too, even though that driving pressure is derived from some of these other vent measurements like tidal volume or compliance, no other vent variable was helpful in predicting once you accounted for driving pressure. And then in contrast, adding the driving pressure always increased the predictive ability of their model when it was included, even in models that they had pre adjusted for other vent variables.
Yeah, I think this gets to the heart of what we're going to be discussing here is that you have a ton of variables, a bunch of things that have been randomized and controlled, talking about tidal volume, talking about PEEP, how we're applying them. And even though we may see some associations with those things, if we do multivariable and we include driving pressure, it ends up being the predictor that is driving their mortality risk. And so this is telling us that this driving pressure may be a better metric to look at on the ventilator than one of these other isolated variables individually or a combination of them that's not taking driving pressure into account. And in just a second, we'll talk about a little bit more about how they know that driving pressure is the controlling variable for this prediction.
Yeah, and so they did a pretty clever thing next where they went back and looked at their population and they looked at the mortality risk of folks when driving pressure, PEEP, or plateau pressure were matched. And they found that there was no consistently increased risk of mortality with higher plateau pressures as long as the driving pressure was stable. And there was no consistently lower risk of mortality with a higher PEEP if the driving pressure was decreased or the plateau was matched. And so, put another way, a higher plateau pressure was not always risky, they found, and higher PEEP was not always protective. It seemed like it was being mediated potentially by driving pressure.
Yeah, that very well said. And I think this comes to probably the most defining output from this paper, which is a graphic that we'll put up as well that shows this, where they really broke this down into three different cohorts. And you can see from this graphic that's really well laid out that the controlling variable is how much your event setting adjustments had an impact on your driving pressure. And so we have previously been thinking things a little bit more in isolation. Oh, I'm going to decrease their tidal volume, but not always looking at what the impact was. And this graphic, I think, really beautifully lays out that we should be thinking about, at least in the confines of a retrospective study, that really the only interventions that are going to have an impact are ones that are decreasing driving pressure, even if it falls out of some of the bounds that we've previously used to make vent settings.
Yeah, I think that was said really perfectly. I think the last little thing that they spent their paper talking about was a pretty clever next step where essentially what we've shown or what they, I should say, have shown, not me. I certainly cannot do this math myself. Was that driving pressure predicted mortality? And so the natural next question could just be: is that just a risk predictor? Is this just a fancy way of saying that sick people are more likely to die? And so they did this mediator analysis, which is this way of testing whether a specific variable that's affected by your intervention has an effect on an outcome that it at least explains part of the result. So, put another way, what this asks is, do changes in driving pressure explain who received the mortality benefit of different ventilator strategies?
Yeah. And so this is asking the right question. We know that something could just be a predictor. Somebody has a high driving pressure, they have a high mortality. But what if we make an adjustment in it? And if we make that adjustment and we think that this is the driver, we should see the change. Now, certainly complex math to show that more than just saying it. But I love that they take the next step to try to take a look at that. And so what do they end up finding?
Yeah, and that is actually essentially what they did found. So driving pressure was a better predictor of mortality than either compliance or tidal volume. Just quoting from the manuscript, the driving pressure mediated 75% of the benefits that they saw in the tidal volume trials and 45% of the benefits in the PEEP trials. And in fact, they actually didn't find tidal volume or PEEP to be independent mediators of survival, which kind of blows my mind a little bit. And just saying that one other way, and again, just quoting from the manuscript because I think they phrased it really well. Survival benefits in the tidal volume trials were proportional to reductions in driving pressure rather than to reductions in tidal volume. And survival benefits that were observed in the PEEP trials occurred in relation to reductions in driving pressure rather than in relation to PEEP.
Yeah. Again, letting the authors speak for themselves really helps this. And again, I think looking at the picture will really help it as well. So we will share this graphic. But just to reiterate, what they're showing here is that in all of these trials, we're adjusting one variable. And the end point or the end goal of that trial is to say, we got to that lower tidal volume, we got to that higher peak, we got to whatever our intervention goal was. And it turns out that the people who are mediating benefit from this were only the ones where that intervention led to a reduction in their driving pressure. And so this is a physiologic measurement that's really showing whether our vent strategies had desired impact beyond just what we're making the setting. Did that actually lower our driving pressure? And if so, then we may be looking at a mortality benefit. And if not, just because the number is lower doesn't mean that we're going to have that benefit. This was a very convincing study and finding. I think that it has shaped the way that we think about ventilator settings going forward, even though it's retrospective. And it's certainly spurred a series of future investigations. And hopefully, we'll have some randomized trials to back up some of this soon. I know that they're in progress. But obviously, there are limitations to this. So we should take it in the full lens. So, what things do we need to know about when interpreting this trial?
Yeah, just like you said, there are, I think, a few relevant limitations here. And this is really quite elegant. It is a very elegant paper, but a secondary reanalysis of RCTs is not an RCT in and of itself. And so, to date, at least at the time of our recording, there is no prospective randomized data that supports actively titrating your ventilator settings to driving pressure. Another thing too is that we don't know the optimal driving pressure. There's been a number of other retrospective papers that would suggest it's somewhere between 10 and 15 maybe, but we don't really know. And one thing that we mentioned at the top of this too is that you can't really reliably measure the driving pressure if someone is making inspiratory efforts. And the reason there is just because your plateau pressure is not reliable. And then lastly, it's in general, driving pressure may be less useful in folks who have low chest wall compliance, like folks with obesity, as a lot of the pressure that the vent applies is functioning to distend the chest wall rather than the lung itself. And so some of these numbers we measure may or may not reflect what the lung parenchyma itself is experiencing.
Yeah, thanks for pointing all those out, Luke. I think they're really important. I think to start in a sort of random order, this number of what the driving pressure should be is an interesting one. We often get quoted now of 15, less than 15 is where we want it. And that kind of comes from this paper where they see an inflection point of mortality starting to increase. But again, that's still based on this retrospective analysis. And it's nothing is a hard data point, right? There's always a spectrum. And so we really want to be trying to minimize it and not just use one number that we're targeting below. The biggest thing about it not being an RCT is that there are multiple ways to titrate your vent to decrease driving pressure. And so we don't know which is the right way to go yet. Should you have a patient and then try to increase their PEEP, see if you increase lung recruitment and then get to a point where the driving pressure is lower? Should you go ahead and lower their tidal volume first? There are different ways to adjust your vent to achieve the same goal. And this paper doesn't tell us which of those methods would be more effective than another. And then finally, I love that you point out patients with low chest wall compliance. We're getting to the concept of thinking about pulmonary pressure and not the total pressure of the respiratory system that the ventilator is working against. There are some studies going forward that use esophageal balloons, try to look at transpulmonary pressure to pleural pressure measured on an individual patient that can adjust and be more targeted of the transpulmonary driving pressure. But from just the vent alone, there may be some patients where this becomes a little less applicable. All that being said, I think it's super convincing and influential paper. And so it's one that we should have in our armamentarium. So, Luke, what is your takeaway with those caveats in mind after reading this paper and analyzing?
Yeah, I think with all those caveats in mind, what I take away from this is that elevated driving pressure appears to be correlated with mortality. How to optimally incorporate that into my clinical practice is a bit unclear, but titrating tidal volume or PEEP to prevent driving pressures over 13 or 15 seems to be a reasonable adjunct to a lung protective ventilation approach. And that in general, we need more prospective data.
Absolutely. Always more data. That's always the next step to take. But yeah, I agree with you. And I will say, especially with something where we're still always trying to figure out the optimal way to titrate the vent, like PEEP, we should be having driving pressure be one of the variables we're looking at. I think the paper is convincing enough for that. And we'll have some more information hopefully soon about exactly what protocol to take to get the optimal driving pressure for a patient. All right. Well, thanks, Luke. Appreciate you taking us through that. This is definitely a paper that we encourage people to read and then look at the graphics as we're discussing, because I think it really helps make these elegant points. But I'm glad that we've rounded out for everyone.
Yeah, this was a good one. I echo that. I think pulling up the infographic we're going to make will hopefully help some of this stick and make a little more sense.
All right. Well, thank you all for listening this summer. We hope that you feel more comfortable with the ARDS literature. This is just scratching the surface, and there are many more papers to read. But we want you to have a good reference for these landmark trials and be able to come back to them anytime you want. And Luke, thank you so much for spearheading this effort and taking us all through it.
Yeah, this was fun. What better way to spend a summer than thinking about respiratory failure?
Yeah, exactly. Like, we'll have to tackle sepsis next summer. You should start thinking about it
Yeah,
now.
definitely. Something simple and not at all controversial.
All right. We'll see you all next time. Thanks for listening.